not so much pain though, mostly the weakness, right?
Super weak, and my shoulder blade continues to pop out.
Right, right. All right. So I know we did the EMG I looked at. I mean, it does show the long thoracic nerve, and then the brachial plexus MRI didn't really reveal any abnormalities. So
It still continues to look like it's the
long
neck,
thoracic nerve, right?
well, the neck area which is causing
Yeah.
all the issues.
Mhm. So that's why we were suggesting doing the epidural injection to see if that helps relieve some of the symptoms you're having.
Okay.
And that can, both be diagnostic and therapeutic. That was the thought process. The other thing I was thinking was evaluation by a peripheral nerve specialist, but there's only one. I mean, these guys are really rare, so we can look into that. There's one guy I know, he's at Stanford, but I'm not sure if he does workers' comp cases or not. But at least I can reach out to him and get some, thoughts from him. But yeah, I mean, I still think, going after the epidural and see if that can relieve some of the symptoms you're having would be the first choice.
Okay.
In my opinion.
Okay, and you said that after you guys got the other MRI done, that you would also discuss other scenarios, possible scenarios?
So depending on if you found any abnormalities there, but the MRI of the brachial plexus doesn't show anything abnormal there. So it's chances of being, because all I'm trying to do is to find a target where there's a problem and address that. But if the MRI doesn't show any abnormalities there, essentially there's no target for me to go after.
Okay.
It's either, right now we've kind of narrowed it down. It's either the the tightness in your neck that's contributing to this, or it's something outside past the brachial plexus where the nerve has branched out, and before it gets to the muscle, that's causing it.
And you guys haven't seen any of that from the MRIs? Any other? The only thing that looks like it's a problem is the neck, then?
Either the neck or something past the. So the way it works is the nerve roots come out of your spinal column, right? They go into the brachial plexus. There's a meshwork of nerves kind of getting intertwined, and then the outcome of that is a bunch of different nerves that go to different parts of your body. Go to your arm, go to your hand, and one of them goes to the serratus anterior muscle, which is a long thoracic nerve.
Okay.
And so either it's after that branching point from the brachial plexus, which goes to the long thoracic nerve, or it's before it gets there, where the nerve roots are coming out of the spinal column.
Okay.
I don't know which one it is, but that's why when we do the epidural, if that helps to relieve, I'm not saying it will 100% resolve the situation, but if it does help to relieve some of the symptoms, get you stronger, that tells you, okay, so it's a pinching on the nerve roots where it's coming out of your spinal column, and when we did the epidural injection, it reduced the inflammation, opened up the space around the nerves, it relieves some of the symptoms. If that doesn't help, then the only option left is that long thoracic nerve, somewhere between where it comes out of the brachial plexus until it gets to actual muscle.
Okay. Another question I have is how long will it go before the nerve won't be, that long thoracic nerve won't be repairable? Like, is there a certain time where nerves can go and then they start to like die or something?
They don't die. So over time, the way simple way to put it is use it or lose it type of thing.
Okay.
But the longer they are under pressure, the longer they are under the insulting cause that's causing the problem, the less chances for long-term recovery.
Okay.
Okay, so the sooner it's treated, the better chances of recovery. Sometimes, but that also being said, it all depends on what kind of injury was the initial injury. Like if it was something that severed the nerve and cut the nerve, chances of that coming back doesn't matter how long it goes from there.
Yeah.
And that injury was so drastic that the damage was done right at the moment. But if it's something that's putting pressure against it, the longer you wait on it, the more long-lasting the damage is going to be. The sooner we relieve that pressure off of it, the better chance of it recovering and going back to normal.
Okay. And I asked her already. What was I forgot again, the name of the steroid and the other chemical that was in there?
The ones I would use for the injection?
Yeah.
The steroid I use is Kenalog or triamcinolone. It's a particulate steroid. and and that's essentially it. That's all I inject inside the epidural space. On your skin, I inject some numbing medication, which usually I use lidocaine. That's just to numb off your skin before I enter the actual needle, which goes to the epidural space.
Okay. And no ill side effects from those chemicals?
So the lidocaine I'm using only on the skin.
Yeah.
I mean, if any, the worst case is like if you have a skin reaction in that area, which is very unlikely, generally speaking. But that's I can never say it's a zero chance.
Okay.
As far as the steroids, generally speaking, the steroids, the main problem with those is they can raise the blood sugar. Usually that happens only in people who have diabetes, underlying diabetes. You don't have diabetes, right?
No.
So, other thing with it is for a day or two it might interfere with your sleep. But again, chances are when you're a young person, you have a healthy kidney, you have a healthy, bloodstream, everything is working fine. So chance of that happening in you is again much less than, say, like a 70-year-old who has stage 3 kidney disease and liver failure and so on and so forth. Other things, obviously with the actual procedure, where I place the needle, there's a chance, because I'm close to the spinal column, there's always a chance of injury to the adjacent structures. But I take all the precautionary measures. I watch under X-ray. I have my landmarks to make sure I don't get close to any critical structures to cause any damage. But again, if I can say the chance is zero, I would never say that.
Yeah. Okay.
Okay. And then one other thing I tell you, like when I do the injection, sometimes you might feel a little bit of pressure coming across the chest, and that's just because that space is tight. When there's a little bit of extra volume, it pushes a little bit of pressure on the nerve, and then the fluid spreads around. So that's the transient pressure that you're going to feel. As soon as you sit up, it's going to go away.
Okay, so it's not going to last very long?
No.
Okay.
As soon as you sit up, the medication spreads around and it's going to go away. It doesn't happen all the time, but it can happen, so I don't want you to feel like, because what it is, like when you're in that position, I do the injection, you feel that chest pain, you feel, I'm having a adverse reaction or something, but that's a normal thing too.
Okay.
If you anticipate that, it's just much easier to tolerate it.
Okay. Let's say we see positive results from this. What would be like the next plan?
So depending on how long it lasts for you. I mean, say like if it gives you like 6 months of good relief, if it comes back, we just do it again. If it doesn't, if it gives you relief and it doesn't come back at all, perfect. You don't have to worry about anything. If it keeps coming back more frequently, then we can say, okay, we know it's tightness in the neck that's causing this problem. We gotta maybe talk to a surgeon or talk to someone who can go in and clean up that space and open up some space. Not, I wouldn't say artificial, because like steroids is a temporary fix.
Yeah.
It lasts only for so long. Okay, but if the underlying problem still exists, that needs to be addressed at some point.
And you address that after the shot to see.
Yeah, generally speaking, my approach is to go with the least invasive treatment. So say like if with an injection and 2 cc of fluid I can fix that, rather than you having a surgery that you have to be opened up and things to be manipulated and cut out.
Yeah.
Why not? We go that route. Worst case is we do it, it doesn't help, we haven't lost anything, we haven't burned any bridges, we still have all the other options available that we can have you evaluated by a surgeon. You can look at your MRI and say, okay, this is where the problem is, let's go after it and fix it.
Okay.
Okay.
I talked with my primary care physician about lightening my restrictions, not obviously so I can go do what my normal lifestyle is, because it's pretty extreme anyways. So he did lighten up on the restrictions. He's no restrictions on the left arm, which there was restrictions before.
Okay.
Lifting my right arm, he said no more than 2 hours a day forward above, and he said really limited above the head. And I was just wondering if like.
Are you okay with that?
Well, yesterday was the first time I was,
Okay.
but I have to tend to my kids, and I gotta grab stuff from the top of the shelves and stuff. So it's like I do that, but it's with really light things, and I don't seem to have any issues. It is difficult. I'm not saying it's normal, but I can do it.
Well, that's good, and I think it's good to proceed in that direction because part of it is like you have the difficulties, you have the weakness, you have the discomfort that you get from it. But at the same time, the less you use those motions, the less you do them, the less your body is going to want to do it, and then over time, you reduce that level of functionality that you want to have.
Yeah.
So the most you can, the more you can do, the better it is.
Yeah.
To say. But at the same time, we got to make sure you do it safely and comfortably.
Yeah. I think you put like some really pretty strict restrictions on me all the way until February, I believe it was. I can't remember exactly.
We can change them. The goal is to give you a comfortable level of restrictions that you can do what you want to do without, making it difficult for you.
Yeah.
So, yeah, we can adjust them to whatever degree you want.
Well, whatever's really safe. I can do a majority of the things. Obviously, I can't go live wrestling anymore.
Sure.
Mr. Dr. Kimmelman said, because I was really stressed out, I was having some anxiety. He goes, try to go back to doing as much of the normal things as possible, but obviously you're an athlete, you're going to know where your limitations are with this new injury, so if something hurts, step back from that a little bit and then find those limits.
You gotta listen to your body.
Yeah.
It looks like you have a perfect insight. Know what your body is capable of doing and limit or restrict yourself to those.
Okay.
Because at the same time, as I said, I don't want to say, okay, don't sit at home and don't do anything, because that's just going to be a recipe for disaster. Over time, you're going to lose all the muscle mass and all the strength you have and whatnot. But at the same time, we don't want to exacerbate the injury you've had.
Okay.
So listen to your body, see what you can do, and kind of gauge it based on that. Slowly, you can build up on that.
Okay.
But yeah.
Are you gonna notate the like my restrictions?
So let me see here. We are. Who's providing you with the work notes? Your PTP is doing that, right?
He's doing my primary. Yes,
primary
he's the one.
Physician, right?
Yeah.
Yeah. So we as a consultant, we just make our recommendations, but I wouldn't necessarily give you a note to what your work restrictions would be. But we make the recommendations.
Okay.
What we
Great.
talked about. Yeah.
Okay.
Should be good. All right.
Okay. Cool. Thank you.
Anything else?
No, I guess I'll call the number to schedule the injection. And
Sure. Tony already has contacted you in the past, right?
They did, but I
Okay.
said I would feel more comfortable if I asked a little bit more questions.
Absolutely, absolutely. And I can also get you a pamphlet on the injection if you want to.
That would be great.
Use it as a reference and
Yeah.
use that later on too.
Yeah, that'd be great.
Anything else?
No,
Big plans for holidays?
work, wrestling tournaments,
Yeah.
coaching my girls.
Yeah. Okay.
Yeah.
But you don't wrestle yourself, right?
No, not anymore. I
Stay
can't.
away,
I'm
right?
hoping that
Yeah.
eventually I'll be able to go back to it.
Yeah.
I really want to,
Okay.
because
Well,
I was competing all the way, up until the summertime.
there was World Cup. The wrestling World Cup.
Yep, and Amit Allure. She
Yeah.
was. We wrestled against her.
Oh, did you?
I don't know if you know about her. She's a girl from here, from Walnut
Yeah.
Creek.
Oh, is that right? I didn't know. I know. I actually know. Originally, I'm from Iran, and I know U.S. and Iran had made it to the final. I don't even know what happened. What happened to the?
Well,
they-
one of the Iranians beat one of the Americans, and the other one beat the American beat the Iranian. So they're kind of 1-on-1 there.
Is that right? Okay.
Yeah.
It's still going on.
No, they're
Is
done.
it done?
Yeah,
Okay.
it's amazing though.
Yeah. So I heard, but I haven't really been following.
Yeah.
I know what's going on.
Yeah, right on.
Awesome.
Thank
man.
you.
No problem. You take care.
You too.
And I'll get you that pamphlet, and contact Tony. Set up the injection. We'll take care of you.
Thank you.
Good job.
So I just follow you for the pamphlet.
Yeah. We can come back and see us in about 6 to 8 weeks.
For the injection. Oh, after the end.
Yeah, I
Okay.
want to see how you're responding to the injection.
Great.
Yeah, that should give you enough information. And let me just give you a little peace of mind. Maybe I have a model that tell you where exactly I'm going to do so. See the model I'm looking for. Right here. These are your cervical vertebral bodies. The space I'm going to be going into is, so this is 2, 3, 4, 5, 6, 7. This is the space I usually go into.
Okay.
Okay, so on the X-ray, I look, see where exactly it is. I place a needle, it kind of slides in here. There's a thick ligament right this space before I get to your spinal column, or before I get to the space that contains the spinal column. I look on their X-ray, find exactly where I'm going, and I have a technique to check for the pressure where I'm going. Once it gets to that right pressure, and I know it's the right place, so I'll inject. And before I actually inject the medication, I inject some contrast dye to make sure it's actually
So
in the right
vivid with it.
space.
I'm really nervous, man.
Yeah, it should be. Yeah, I do